So, welcome to the second SOWRA Sessions, and my blurb you didn't hear was essentially saying thank you for joining us. We've got Max Byrne, one of our anaesthetic registrars and knee model, and we've got Sam King, one of our regional fellows, and technical support behind, so very glad to have him here tonight. And then we have me, I'm Jo Wilson, one of the consultants here, interested in regional anaesthetic education. And we've got Dr. Matt Ullman, who's a regional anaesthetist, who many of you will know, and has a good, huge amount of experience in knee arthroplasty. So today we're going to talk about regional anaesthesia for knee surgery, mainly arthroplasty, and we'll try and touch on some soft tissue operations such as ACL Reconstruction too. On your slide, which hopefully you will see soon, we've got it as a small box here. Tell us in the chat if you can't see it bigger. That we're going to use Slido again. Now there's a QR code at the bottom of each of the slides, and if you click through there, add any questions you want, and then we'll pick those up probably towards the end, just so that we can kind of collate everything. All right, everyone happy and can see the screen in big form? Okay, great. So why is this important, and how has it changed over the years? So I mean, arthroplasty is obviously a very common procedure. We do stacks of them a year. The numbers are only ever increasing, both within the UK and worldwide, really, and the demographics of the patients is changing, so they're getting older and more polycomorbid as well. And the length of stay has changed dramatically over my working career, and with it, we've had to adapt our techniques and the ways we used to do things, with an emphasis, changing emphasis now really more from making the leg completely numb for days to enabling patients to get up and mobilizing. And certainly within the UK, and I suspect worldwide, the focus is now really on aiming for sort of ambulatory arthroplasty, or even if that's not achievable with our frailer patients, to at least getting them in just for maybe one or two nights at most. And so we've had to think about what we're doing, and the focus has shifted, as I say, from providing a dense block to more of a functional recovery, with the early mobilization as the sort of the key metric that we're looking for now. And how have those challenges come about, really? Well, we've had to change certainly our block techniques. There used to be much more of a focus on things like the femoral nerve block and sciatic nerve block, which again used to provide a very dense, numb leg for days, if not certainly not something that the patient would mobilize with the same day. To sort of more motor sparing techniques, which are enabling the patient to hopefully get up and about, and in many places start walking the same day. Great. And what does that mean for us as anaesthetists, when we're doing this? It's quite hard for us because we're very much keen on numbing things and providing pain relief, and we still want to provide pain relief, but we're very keen now on enabling that mobilization, which sometimes is hard to sort of square because it's not as dense a block. And so if you grew up used to providing a numb leg for 24 hours, actually seeing patients who now may have some pain afterwards is perhaps slightly uncomfortable. But nevertheless, it's getting that balance right between good enough analgesia that enables them to walk, but still is humane, and because these patients can be in pain for not only a few days but for several weeks after their surgery. So knee replacement is unlike hip replacement surgery, which is perhaps painful for 24 hours and then actually subsides quite quickly. This is going to be sore for weeks. So before we get into talking about the actual blocks that we're going to, can you just go over the knee anatomy for us? Sure. Okay. So there are a number of nerves that supply the knee, and basically it subscribes to Hilton's law, which is the principle that nerves supplying the muscles that cross a joint also give off innervation to that joint, and also will supply the skin overlying that joint. So not surprisingly, much of the knee innervation comes from the femoral, sciatic and obturator nerves. And you can see in this diagram here that there is the femoral nerve has a number of terminal branches which are important for knee innervation. The nerve to vastus medialis and the saphenous nerve being the two most important, but also to some extent the nerve to vastus intermedius. And then from the, if we look at the back of the knee, the posterior innervation, there's something called the popliteal plexus, which is formed from contributions from the tibial nerve and from the obturator nerve, and that supplies the capsule of the knee, and so that's an important target for us, and that will deal with the sort of the deeper dull pain that patients often get after surgery. There are also these nerves, the geniculate nerves, which most of us may not have necessarily thought much about, often a bit more of a chronic pain interest, and our interest in blocking these has now come from those sort of chronic pain origins. So the geniculate nerves are nerves that form, there are 4 of them: superior lateral, superior medial, and infralateral and inframedial, and they sort of come up from around behind the knee and innervate the sort of the more anterior structures. The lateral ones principally come off the common perineal nerve. The superior medial is a branch in most cases off the saphenous, but also can come off the tibial. And then the inframedial geniculate nerve is off the tibial nerve, and so they're important targets for us. And that's the joint innervation, and there's also the cutaneous innervation, which we'll cover a little bit later.
So for sort of a primary anaesthetic choice for arthroplasty, what would you do as your recipe? So
obviously there are 2 fundamental choices which come to us. It's either a GA or it's a spinal, and we nowadays generally prefer spinal anaesthesia. If you're doing a GA, it needs to be something that is short acting and will wear off quickly, and have awake patients that hopefully can participate in physio. Spinal anaesthesia has a number of advantages, which is why it's sort of, I say being pushed, but generally much more the standard now in certainly in the UK and parts of Europe. It has the advantages that it provides good early analgesia, but will wear off in a suitable time, and it's very suitable for the increasingly older and polycomorbid patients that we're dealing with. And it provides a sort of degree of standardization for patients, which is again desirable for both the post-anaesthetic care unit and the ward beyond that. And the game's sort of changed a bit in the last few years, really, with the introduction of the shorter acting spinal agents, which offer less problems like urinary retention, and also again much faster motor block resolution. So I think if you look at this sort of which is better, GA or spinal, was a question that the Icarus group looked at, and whilst the evidence for knee arthroplasty is perhaps not quite so clear cut as for hip arthroplasty, but you can see overwhelmingly here really sort of positive outcomes associated with spinal anaesthesia, and very little in the way of negative outcomes. So spinal where possible, but obviously it's a patient choice factor as well. And I actually I don't mind giving a patient a GA if they want, because we can get around the other issues with our blocks.
Yes,
so.
Yeah. And so we'll maybe talk more in detail about that later, but we'll move on to the analgesic sort of strategy.
Sure. So most of our patients will be having a medial parapatellar arthrotomy. So that's an incision along the medial side of the patellar tendon and down on the medial side of the knee. And so we don't need to necessarily block all of the nerves that innervate the knee. The ones that are most important are the saphenous nerve, the nerve to vastus, and the geniculate nerves that we mentioned. And of the geniculates, I tend not to block the infralateral geniculate nerve because it contributes perhaps a bit less towards the standard knee incision. And we don't need to block the common perineal nerve or its branches. And we're aiming to block posteriorly, we're wanting to block that popliteal plexus, which is, again, from the branches of the tibial and the obturator nerve. So that will guide our choice of block technique. Sorry, Joe's just repairing some things that have fallen over behind the scenes, which it's all gone well technically. today.
Okay, nothing taped on.
Nothing that a bit of tape hasn't sorted out. That leaves us with a set of core blocks, which I think most people should have at their disposal. Sam's now going to show you a slide, which is the core blocks which we're going to think about doing, and that's blocks which target the anterior innervation, which is the femoral triangle block, and then the posterior innervation, which is our iPACK block, which is a kind of form of a sort of targeted local infiltration targeted by us. Then we've got reserve blocks which will be needed for there's only a fair select few patients. The femoral nerve block still has a role for difficult patients, and we can target the posterior innervation by doing an isolated tibial nerve block, which is a selective block of part of the sciatic nerve. And then there are perhaps some more advanced blocks which are not necessarily technically difficult to do, but they are just another thing to layer on to your practice, which may be too much for a lot of people after a spinal and then 2 other blocks in someone who's perhaps an already challenging patient. But that's the cutaneous nerve blocks and the genicular nerve blocks. So we'll show you those. And all of these blocks, we're aiming to have opiate sparing techniques, which are motor sparing and kind of quick and reproducible for the whole department to be able to do. In terms of efficacy of analgesia, as we said, the game had changed a bit. So Sam, if you just go back a couple of slides, you've got, if you're looking at provides the best analgesia, not surprisingly, blocking the femoral obturator and sciatic nerves is going to give you the best rest pain and the best opiate consumption. And then sort of middle down the table, we've got things like surgical local infiltration and a ductal canal block. But if we then change the focus and say we're not so focused on rest pain and opiate consumption, and we look at length of stay, then there is a change in the rankings, and a ductal canal block comes out at the top of the table, shortly followed by surgical local infiltration. And our more traditional techniques, such as femoral and sciatic nerve blocks, are much further down the table, associated with longer lengths of stays. So this is now filtering into our protocols and how we do things.
So if we start with the anterior knee analgesia,
sure.
Can you show us how to do a femoral nerve block? Yeah,
so I mean, this is going to be familiar for most people, and certainly it's not. And we're not going to spend any length of time doing this, but the femoral nerve block is something we need to be able to fall back to if things get difficult, and it also just sets the scene for the rest of the anatomy. So we're coming in at the top of the thigh, just at the level of the crease. And if I come down, you can see that this femoral artery in the center of the screen has bifurcated into 2, and I want to come proximal to that bifurcation. And as I move over laterally, you can see this iliopsoas muscle, which is this muscle in the center of the screen now, with this bright fascial layer above it. So this is our fascia iliaca, the fascia iliacus. And we've got 2 fascial layers. We've got fascia lata, which comes over the top of everything, and then fascia iliaca, which comes down over the femoral nerve and underneath the artery. And as you can see, immediately adjacent to the artery is a hyperechoic, sort of elliptical shaped femoral nerve. I'm just going to pop the screen down a bit. You can see here, it'd be very easy to come in with an in-plane approach from laterally and get either above or below the femoral nerve. And typical volumes for this would be 10 to 15 mils, just enough to surround that nerve. And 0.25% bupivacaine would be what we'd be typically using for knee arthroplasty. And that will give you, a block that generally will have resolved by the next post-operative day, but it's certainly not an option for the patient mobilizing that day.
Was there a particular patient you could think of as an example that would be a good patient for people to look out for?
So some of our patients are quite challenging. So in patients that are living with significant obesity, they're going to have very large legs, and so the femoral triangle block is going to be much deeper, and so we're going to struggle to necessarily get good views, and there are ways and means around that, but fundamentally sometimes you just run out of depth and the view is poor. But these have got to work, so there's no good doing a cross your fingers and hope block that is not going to provide any analgesia. You've done the patient a disservice. So for those patients, and often they're not patients that are going to do well and getting up and about that day anyway. So prioritising analgesia may be a solution for them. So it's a reserve block. Please don't go out and do this to every patient on your next list. It will cause us lots of grief. We'll get lots of complaints, but sometimes it's still got a role.
So moving down to femoral triangle.
Sure. So coming down to the femoral triangle block. So we're now putting our probe on the anteromedial thigh. We've got this characteristic shaped sartorius muscle in the center of our screen with the superficial femoral artery underneath it. And there are a few muscles around it, one here on the medial side, one here on the lateral side. You can see the femur down to the bottom left. So I want you to look at this muscle here on the medial side. This is adductor longus muscle, which forms the top medial border of the adductor canal. And as we scan down the leg, it disappears and is replaced by this muscle, which is adductor magnus. And we're looking to find the apex of the femoral triangle. So the femoral triangle is defined anatomically, the apex of it, by the point at which the medial border of sartorius meets the medial border of adductor longus. So it's this, if I just put the calipers on again, you can see at this point here, the medial border of sartorius meets the medial border of adductor longus. And that's the apex of the femoral triangle. Beyond that, we're in the adductor canal. And if we were to scan down, femoral artery would stay underneath sartorius and then would drop away into the adductor hiatus and go through to be continuous with the popliteal fossa. And it's at this level, if we look to the lateral side of the artery, you can see a hyperechoic structure immediately lateral underneath sartorius, and that's the saphenous nerve. And that's our primary target endpoint. But you can also see on top of vastus medialis another structure, this nerve here, and this is the nerve to vastus medialis, and it's really nice to be able to see that so clearly, and it's not something we normally see quite so clearly. So as I scan distally, I'm now moving my probe down Max's leg, we can see that that nerve runs underneath, along the surface of vastus medialis, and is sort of innervating that muscle. Ultimately, if we scan proximally, it will join up with the saphenous nerve, and I'm now sort of a fair way up Max's leg, but if we take that, at this point, they're separated. So if you were to inject at the, we would bring our needle in, there are a couple of ways we can do it. We can either come through the plane between sartorius and vastus medialis, or we can come through the sartorius muscle itself, and that choice will be a bit determined by the patient body habitus. As you enter through the vascular-adductor membrane here, you get a little pop quite often, and then when you inject your local anaesthetic, you should get fairly well circumscribed spread around the saphenous nerve. And if you were to inject 15 to 20 mils there, you would probably almost certainly block the nerve to vastus medialis, whether you saw it or not. But if you can see it like we can, it makes sense to block that as a separate structure. And so in this scenario, you know, I might choose to come along this plane here, block the nerve to vastus medialis with say 3 to 5 mils of local anaesthetic, and then continue on down to the to block the saphenous nerve next to the artery. So those are the two key endpoints really for a femoral triangle block. But don't worry if you can't see the nerve to vastus. If you just were to get to this point next to the saphenous nerve and get very well circumscribed spread, and you put in 10 to 15 mils, you should get retrograde spread up, which should reliably block the nerve to vastus medialis anyway.
You mentioned quite a few things, sort of advantages of the block. What are the limitations of this block?
Well, it's a motor sparing technique. That's an advantage, as I say, and it will enable mobilization. The limitations are it doesn't supply everything. So this is just one small part of a knee innervation. So we haven't touched upon the genicular nerves and we haven't touched upon the posterior innervation. So you can imagine a lot of the studies now looking at knee analgesia, you know, have implemented, you know, spinal and adductor canal block. It's not surprising patients will still have some pain afterwards because you've not blocked everything. So before we
go much further, there's a live demo you have of the.
Well, yeah, not quite live. Sorry, because live so this is just showing. Just need to click to play. That's it. So that's just showing that point of the apex of the sartorius and the adductor longus, shows that we're at the level of the apex of the femoral triangle. And so our needle is coming in. I'm going through the sartorius muscle. You can see the saphenous nerve just pointed out there, and there's a little pop as we go through into through the vascular adductor membrane. And then when we inject our local anaesthetic, we can see that the nerve sort of moves freely within that pool of local anaesthetic, often becomes much more visible. And we're injecting, I don't know how much volume I used for this. I think it was probably about 10 mils in total. Mm. What I want you to see is, so as I've just pointed there's something that's beginning to highlight a bit underneath sartorius, between sartorius and vastus medialis, that I noticed, and I think that's the nerve to vastus medialis. So it wasn't initially visible, but now I put some local in, it has become visible. And so if we now pop around that and inject around that, we can see that the nerve to vastus medialis does sort of, well, what I'm calling the nerve to vastus medialis appears and seems to get surrounded by local. And if we scan up and down in a second, you can see that you've got that nice circumferential spread that persists, and so you can get the idea that's sort of forming a canal that is continuous.
So how about posterior knee?
So posteriorly, there are a couple of blocks we can do. We've got our basic block, which we want everyone to do, which is the iPACK block, and then we could talk briefly about just an isolated tibial nerve block. So for an iPACK block, I'm going to show you there are a couple of approaches. I'm going to show you sort of the lateral approach, which I think is easiest, because if you're familiar with doing a popliteal sciatic nerve block, you're familiar with sort of the orientation. You're still stood on the same side of the patient you've been to do your femoral triangle block. So we're just going to bend Max's leg up like this, and we're using a curvilinear probe here. So this is a curvilinear probe, and it just gives you a bit more of a tactical overview of what you're looking for. Sorry, I just need to switch the ultrasound over. So we've got our probe on the back of the knee now, and we're looking I want to look into the knee. So in the center of the screen, you can see the artery, and you can see a white line of the femur. Okay, and if you're very eagle-eyed above, you can just see what is the tibial nerve up here. So there's our artery, here's our femur. So I'm now going to tilt my probe, and I don't know if you can see the movements on the camera, but I'm just rocking my probe to point towards the knee. And as I do that, you see that these two condyles of the femur appear, and you can just see sort of a notch in between the two. So having found that point, that's sort of our most distal point. And then from there, I just rock my probe back again until the femur flattens off. So here we've got a nice flat femur, and we've got our artery up here. So iPACK stands for infiltration between posterior to the artery and the capsule of the knee. And that's literally what we're doing. We're going to be approaching to the lateral side, and we're aiming to bring our needle into this zone here between the capsule of the knee, which is adherent to the femur here, and between the artery. And hopefully we're staying well away from the nerves, which are up here. So this is a motor sparing technique, and it's no different really to the surgical local infiltration analgesia that occurs, except we're hopefully putting it in the right place under guidance and thinking about it. So that's the main attraction of doing it. So it's really simple. Probe on like that, condyles of the knee, flatten your probe off again, and then I tend to do 3 passes. I bring my needle in horizontally, so I'd say like you can look over the side of the screen, see we're about 2.5 centimeters in max, which is very, very superficial. And I would measure up and insert my needle so that it would have quite a flat trajectory across here. And I bring it to the edge of the femur over here, and then I'm infiltrating this space. And I think we've got a video which shows that when we can talk through as we do it. Before we do the video, we'll just talk about why we would do it. So if you add in an iPACK to a adductor canal block, there are important improvements in both pain and functional outcomes like range of motion and number of steps taken. There's also a benefit of iPACK over and above LIA. So compared to LIA, iPACK patients were in several of these studies shown to have better pain outcomes than those that got surgical LEA, and I suspect much of that is down to the LEA being put in the right place. Yeah. What is of note is that if you add in an iPACK to surgical LEA as well as your adductor canal block, then really you don't get much of an improvement. There are minor functional outcome differences which are a little bit tenuous, but it doesn't really affect analgesia. So if you're going to drop, if you're laying on added blocks, this is where this becomes relevant. This is one you could use to and then ask the surgeon not to put posterior local in. We tend to do, in our protocol, we tend to include surgical LEA as well as these blocks, even though the evidence says we don't need to, because it caters for the fact that sometimes we don't put the local in the right place, sometimes the surgeon doesn't put the local in the right place, but ultimately the patient will get a good outcome. Now, if we just look through that video, the similar kind of scenario, we're rocking in to look at the knee condyles, coming back to a point where it flattens off. You can just see a very bright tibial nerve above that sort of dark pulsatile vessel, and then my needle is coming in, I think from the left. There we go, needle's coming in now, and relatively horizontal needle trajectory. I seem to remember this was quite a challenging one to do. I bring my needle into the level with the femur, and then I'm infiltrating as I withdraw my needle, and I'm using 20 mils of 0.5% bupivacaine with adrenaline. I think adrenaline helps a bit to keep it in the right place. And I'm doing several passes, so I inject 5 mils at a time as I withdraw my needle, and then just one sort of final pass a bit closer to the artery. So you're putting, by putting it in several layers, the hope is you're going to catch those nerve fibers that are coming from the nerve, the tibial nerve, and the obturator nerve up above, down towards that capsule of the knee. And this final little bit of local just going into the tissues there. So it's really simple, quick and easy. It's looking for some bony landmarks. You're not looking for a nerve. So I think it's something that everyone can do, and it provides a good outcome.
Yeah. So moving towards some of the other second line block you could do with the isolated tibial.
Sure. So isolated tibial is again something that should be within the realms of most people in their skill set, because if you can do a sciatic popliteal block, which again is a plan A block, then you can do this. It's just coming a little bit further and just targeting and putting a smaller amount of volume around one component. So we're going to keep the leg in the similar kind of position to we had it before, and I'm coming into the popliteal crease. Let's pop the depth down a bit more. Here's our femur, and you can see the artery in the center of the screen, and just to the right, hopefully you can see a hyperechoic structure here and here. So this is the sciatic nerve. We've got our tibial component and our common perineal component, and I'm just going to scan distally, and you can see now that the common perineal component is coming off up here, and the tibial component is persisting with the artery. Okay, so what we want to do is basically come to a point whereby these are sufficiently distant, and again, Max has got a very thin leg, and the distances are quite short. I'm complaining about having too thinner leg. We see here the tibial nerve is immediately above the artery in the center of the screen. Let's put a bit more gain on, which might just show it a bit better. So we would approach from the lateral aspect, and doing that, you've got to be really careful to see, having seen that common perineal nerve, you want to avoid it, and then you're aiming to get into the sort of sheath around the tibial component and putting in maybe just 8 mils of local anaesthetic maximum. And so just enough to get a block of that nerve, but not so much that you're going to get spread to the common perineal. And this has been shown to provide effective analgesia, equivalent to that of a sciatic nerve block. But what it should do, if done properly, will not give you a foot drop. So patients can still ambulate. They will have a numb sole of their foot, which is important to tell the physios about and tell the ward, so that they don't get fearful of mobilizing them, and it needs to be done with care, but they should be able to walk. And a lot of the functional studies looking at this have shown that their numbers of steps walked, etc., is good, and there's definitely a benefit to doing it. So I'd use this block again for patients who perhaps where analgesia is more prioritized, and I find if you were to do a femoral nerve block and a tibial nerve block with a GA and go and see the patients, invariably they're comfortable in recovery. It's very rare that they have any kind of breakthrough pain on top of that. So it does provide quite effective analgesia. So it's getting quite a dense block of that popliteal fossa, popliteal plexus, and it's nice as well because it's a nerve. I am blocking a nerve. I know I blocked the nerve, and so I use it in patients that are perhaps again larger patients where there's a larger volume to cover, or patients who are maybe having revisions, or where there's more complexity or more chronic opiate use, etc., where I want just more, and we're not prioritizing that early mobilization.
Sure. I think there's a video.
Yeah, we've got a video to show you an isolated tibial nerve block. So essentially, we're just getting a spread around that tibial component, and you're getting a nice haloing of that nerve.
Moving on to some the advanced blocks that you touched on before, can we talk through some of the anterior?
We're calling these advanced blocks. They're not difficult to do, but they are things which you can layer on in your practice. And so I did a lot of femoral triangle and iPACK blocks, and started to get, and even layered on the geniculars, and started to get feeling quite good about, certainly in the slimmer patients, about everything was bang on the money. But invariably you get caught out with sort of anterior knee pain if I stopped using the surgical local infiltration. This is because of the cutaneous innervation of the wound is covered by the anterior femoral cutaneous nerves. And there are, if you look at the anterior thigh innervation, there are three principal nerves. Obviously there's the lateral cutaneous nerve of the thigh, which is a separate branch of the lumbar plexus, which is not what we're talking about here. It's lateral, so it's not really involved in our knee incision. But there is the complex of the anterior femoral cutaneous nerve splits into a medial and intermediate femoral cutaneous nerve, which supply the skin over the anteromedial knee, and exactly where our incision is going to be. Now these nerves are superficial, and they run in the plane above the sartorius muscle, so that we can hope to see them when we do our femoral triangle block. And it's thought that they not only innervate the skin, but they may innervate the fascia underneath, and that may sort of have an important kind of role in pain, post-op pain as well, because everything's about fascia these days, isn't it? How the role of the fascia and various things. So I'm going to put my probe on the where we would be doing a femoral triangle block, so this sort of level, and I'm going to put the depth down, and we're looking in this plane above sartorius. Now I have to warn you, you're going to think that I'm making this up, because they're not that obvious in Max, but hopefully in the video that we're going to show you, that they will become a bit more obvious. And what we're looking in is in this plane up here, we're looking at little hyperechoic structures which persist as we move distally. So I'm scanning distally here, and you can see there's a little white structure here which persists. Okay, and it stays. I'm scanning down the leg, and it's staying there. And if I track it back up, trying to keep it in the center of the screen, pretty much confident that that is one of them. Okay, now there are several, so it's not just one, and there are several to be seen. That was the most obvious one in Max, but they lie in this plane, and there's often one over here. And if I just put a bit more depth on so you can get a bit more tactical overview. So this is sartorius, This is rectus femoris and with vastus intermedius underneath. And there's also normally one over the top of rectus femoris as well, which would be somewhere in the zone up here. So you see, this is normally a plane, that's sort of a fatty plane here. And you see in Max, it's just a layer of fascia. There's just no space in there at all. But you would come into this plane, even if you couldn't see them, and there's maybe something here, you'd infiltrate, bring your needle in from sort of the lateral aspect, and I'd aim to basically, using an 80mm needle, bring it along here, this plane, and target the structures that look like little white hyperechoic structures. And you
sometimes do that with your femoral triangle block at the same time?
Yeah, I can do it. Well, I do it as a separate needle. Often is a separate needle puncture, because the point at which you get the best view of the nerves may be a little bit more proximal. I think we might have a video of that which might just show them a bit better. So you can see this white hyperechoic structure here. It looks a bit more convincing than in Max. And this is a bit more lateral than sartorius. So I'm starting laterally, and then I'm going to be coming medially. And sartorius is coming into view. I've already done my femoral triangle block, which is why it looks a complete mess underneath it. And then again, there's some little white hyperechoicities in the center of the screen. So I've taken a separate needle puncture to reach these. So again, just a couple of mils around each of these, and then just moving along a couple of mils along each. So depends on how many targets you've got, but typically I would end up using maybe a total of about 6 to 10 mils to get all of that. And if I couldn't see them, then you could do a targeted injection along that plane. Though to be honest, if I couldn't see them at all, I just get the surgeon to put some skin local in. I mean, being pragmatic, if you can see them, it's nice to do. But if not, 20 mils along the wound will achieve the same kind of thing.
Great. And then geniculars, can you talk us through the genicular?
Sure. So there are 4 geniculate nerves that we can potentially block, and I'm only going to focus on the 3 most important, which are the superior medial, superior lateral, and inframedial. And that's certainly where the evidence base for their efficacy has come, by doing three nerves. There was a lot of reluctance to do a more lateral the infralateral block, because if you look at where it is, it's very near where the common perineal nerve is, and so there's a worry of damaging the nerve and giving a patient a foot drop. So it's near where the common perineal nerve is coming around the head of the fibula, and it's also just not so much involved, although it does get, obviously that bit of the tibia does get resected. It's not so much involved in the incision as the rest of the medial side. So I'm going to talk about those 3 nerves. I'm also going to talk about the nerve de vastus intermedius, which you can see coming down the center of the screen there, just above the patella, and we'll cover that as well because we can block that at the same time. So there's 4 injections, 3 geniculate nerves, and 1 nerve de vastus intermedius. So I'll start with the superior-medial. Okay, so my probe is on the, let's turn it around a sensible way. My probe is on the medial side of the knee, just about, I've got the patella here, and I'm about 2 centimeters above the patella. And as I scan down, you can see this bone here. So this bone is the femur, and so the beauty of this block is it's just a bone as a target endpoint. Now, if you see, there is a point at which the femur starts to flare up, which is about here. Okay, so you've got the femur going from being, relatively shallow line, and suddenly the angle takes off. And there's also a vessel here. And so the geniculate nerves often run with the geniculate arteries, and very conveniently on this side, we can see one right in the center of the screen. And it's an outer plane technique. So I would bring my needle in outer plane, parallel to the ultrasound probe, straight down onto the femur, aiming to hit bone, and then injecting sort of 3 mils or so at that point at which the femur flares up. The very, very similar thing on the other side. So I'm now going to the superior lateral. So I'm putting my probe on the other side of the leg, and we've got a similar kind of picture we've got the femur is relatively flat, and then there's a point at which it flares up, and again, roughly this sort of point. Now on this side, you can't see the geniculate artery, but it doesn't matter. You just put your needle there and inject, and you should get it anyway. So again, bone as an endpoint, really nice, quick, and easy to do. I might be right as you do as well. And then just going for the inframedial geniculate nerve, I've come below onto the tibia, so I'm onto the anterior tibia on the medial side, and I've got my probe at that sort of similar sort of 45 degrees angle, and you can see how again there is a point at which there is kind of a slope up onto the tibia. So tibia is relatively flat, and then it kind of takes off at this point, and that's our target endpoint about here. And again, often there is a vessel. Can't see it here. I'm just scanning a little bit either side to see if I can see it. If I can't, but that would be our endpoint there, roughly the center of the screen. Again, needle straight down onto there, 3 mils or so. And lastly, the nerve to vastus intermedius. This runs down the underneath the vastus intermedius muscle on the surface of the femur. So I've come just above the patella, okay, and I've got the femur in the center of the screen, and I would be aiming to bring my needle straight down onto the femur, okay, and we inject and get spread of local anaesthetic going either side, just lifting that muscle layer off, and again 3 to 4 mils is sufficient to block the nerve to vastus intermedius there. So you can see they're potentially quite quick injections that once you get your flow and get used to seeing them, they don't really take much more than 5 or 6 minutes to do, but they are another thing to worry about. And I think from personal experience, they add to analgesia. There's not been a lot of published evidence out there, unfortunately, in terms of randomized controlled trials. There is a nice study from Jeff Gadsden's group. I mean, he's really brought these into prominence, and I don't recommend you all to go to his YouTube site, which we signed down there at the bottom right, and watch his genicular nerve block videos. So they did a study. Again, it's a small study, but patients with all of whom had had a ductal canal block and an iPACK, and they added in geniculates versus a sham block, and they've got roughly a 60% reduction in opiate consumption in the first day, and by the end of 2 days, just around about a 50% reduction in opiate consumption, with an early effect on pain scores, but otherwise only in the first 6 hours. But you know, that can be important. We're cutting opiate use, which is important, and that early pain relief can make the difference between a patient getting up and out of bed that day and not. So concerns with these, they are injections that are near the joint, and you have to take that really seriously, and it's your responsibility to make sure you're using a full, aseptic technique for it. So I tend to make sure I've got sterile gloves, and often I will do these as the first block I do. We will then
prep stick.
So the surgical prep stick is useful because often they've got the dye in it, and that dye shows the surgeon that you've been taking it seriously. And then when you will have sort of 4 little puncture holes around, you want to wipe the blood off them so it doesn't look too disastrous either, so they don't get upset by it. But you are near the joints, so you need to take it seriously, because a joint infection obviously is devastating. But there's no evidence for that, but you are much nearer their territory.
And so talking about, we'll move to the video now.
So again, this is roughly, I think, in the sequence slightly opposite to the sequence we've got. So superior lateral, you can see that little pulsatile vessel in the center of the screen. We've got a needle coming. You can't really see the needle because it's out of plane, but it's just coming and then injecting down, and you see as we inject onto the femur, the muscle layer just lifting off there. Ideally, you'll see the muscle layer sort of lifting off. Doesn't always. Superior medial, again, needle coming in from the top, and again we're going to get that lifting off of the muscle layer, And we're just putting in 3 mils. That's sort of enough to get spread, which is good for conserving volume. Hopefully here, this is the inframedial. You can perhaps see a pulsatile vessel in the center of the screen. I think I might even point to it. There we go. That's probably the genicular artery there. When we're coming down adjacent to it, try not to hit it, but adjacent to it. And then when we inject, we're again surrounding that area. So practically, there's not this is not a see a nerve and surround a nerve. It's get down onto a bone and inject local anaesthetic, and it can become quite swift once you get used to it in your practice. This is the nerve divartus intermedius. Again, needle straight down onto the femur, and you can just see that local anaesthetic spreading both sides. There was a hope that some people were suggesting you can inject at that one point, and then with a sufficient volume of local anaesthetic, 20 mils or so, you'd get spread down both sides, and you'd block both the superior lateral genicular, the superior medial genicular, and the nerve divartus intermedius. Unfortunately, I don't think that's ever. I think the preliminary work on that suggested that perhaps the spread is not quite so reliable. So whilst it's a nice idea of doing a single point injection, I don't think we're there yet with the evidence to support that.
And if we could talk a bit about surgical infiltration, where did that come up, and how should we?
So surgical infiltration came in sort of the ERAS era back in sort of the mid 2000s, and obviously the function became the goal, and this was something that didn't affect patients' motor blocks, and at the time nerve blocks were seen quite negatively, and you can be slightly skeptical about why this might have happened. It gave control back to surgeons, so it's attractive, and it was quick or quicker than us. Particularly at the dawn of sort of ultrasound, when people were going off and taking quite a long time to do nerve blocks, it didn't give motor block, and it was something quick and easy. And if it was done well in suitable patients, it could provide relatively equivalent analgesia to other techniques, such as femoral nerve block at the time. The trouble is, it's like all things. It's great if it's done well, but it's not always done well. It involves high volumes of local anaesthetic, which again can be an issue. There are about 101 different recipes. People have put all sorts of different things into it. They put non-steroidals, clonidine, steroids. Everything's gone into it at some point. So a lot of the studies have compared different things, which have shown that's one of the problems with analysing its efficacy. And as it's become much more widespread, it often became quite a delegated task, and that's the thing where a lot of us who did regional and did regular orthopaedic lists had quite a negative view of it, because the lead surgeon would often disappear and leave it to a trainee to do, who hadn't been shown how to do it properly, and therefore the outcomes were not as good. So I think if you're a young fit person who's going to do well, if we were going to do Max today and do a knee replacement on him, he'd be fine with surgical ear. It might be sore, he could have some opiates, it wouldn't be the end of the world. But potentially it's not a great option for the more polycomorbid patient, and potentially with more pain. So its main appeal is the motor block, or lack of it. But its analgesic effect is variable. But that said, in the real world, so is our block efficacy. So if you take everyone in a department doing a knee list, there'll be people who are really good and detailed at doing their nerve blocks, and people who perhaps accept slightly different endpoints. And again, if the local's not in the right place, it's not going to work. So if you combine both of them, this is where we are nowadays. It's the best of both worlds. Ideally within safe doses for the patient, and I'm not too humble. I'm not too proud now to be grateful for it, because you can try and refine this as much as possible, but you just want your patient to be comfortable, and these are hard. They're hard to get right with everything. So it definitely can help and smooth the edges. So
if we're adding on a few blocks, how do we then combine safely in our sort of our protocol, where we have a patient who has surgical ear as well? How do you have a sort of? So
you need to look at your total dosage. Obviously, our standard regimen for say a femoral triangle block and an iPACK might have you using 35 to 40 mils, 0.25%. And then if you were to layer on, you add on cutaneous nerves, that's maybe another 5 to 10. Geniculates is maybe 10 to 12. So you might be up to 60 mils, and then you've got to drastically shrink your volume. Now, from my practical stances, we have two strengths of Leo. We have a sort of a 40 mils and 100 of bupivacaine, 0.25 and 140 mils or 30 mils, depending on your weight. So if I'm need to reduce my volume, first of all, I use the weakest solution, which gives me more volume to work with. And then you just need to do some maths and to how much you've got left and how much you can use. And there might be a point, it might be that there's not any point doing it. And if you've targeted all these things, you shouldn't need to. So if you're good at doing your geniculates and you're good at doing your cutaneous nerves, you shouldn't need to do the surgical LEA. But if you had to sacrifice anything, then you maybe take the volume of the surgical LEA out from doing the posterior capsule, because you've done your iPACKs. So you can say, well, don't put it all anteriorly, put what you've got. And then sort of 30, 40 mils that they've got goes a lot further for them.
And we were going to come back and touch a little bit on spinals for arthroplasty. How do we get that right when maybe we don't do an arthroplasty list?
No, so this is a difficulty of parachuting into lists, particularly when you don't know the surgeon, because you don't know how long they take, and everyone's got their own view of surgical timings, and everyone's been caught out. Prilocaine has been a game changer for the quicker operations because it wears off just the right length of time. Not so soon that they're going to be in agony and recovery, but you can get all your multimodal analgesia on board, but it will wear off. They get low rates of urinary retention, so we don't need to catheterize them. And typically, you go and see them 1 to 2 hours afterwards. They're already starting to move their leg, and sometimes they've been out of bed or whatever. So that's suitable for procedures less than 90 minutes. And then we've got this, it's quite clear cut. Once you go beyond 2 hours, really you're in the territory of conventional spinals with 0.5% bupivacaine, whether it's levo or normal bupivacaine. Obviously there's a risk of urinary retention with that in some patients, and we've just, you've got to make your decisions about what you do about that. But there's this in-between zone, and that's where a lot of our surgeons unfortunately sit, sort of between 90 and 120 minutes. And we've had quite a lot of success using 0.25% racemic bupivacaine. I don't know why it has to be racemic, but apparently, that's something that's been passed down through folklore. It seems to produce. If you try with levo, you don't get as good of effects. So probably just levo slightly less potent. You're using a smaller dose of bupivacaine, and hence you get a lower urinary retention rate, and it wears off, relatively predictably. The catheterization rates are low, and it seems to be okay. And I use that quite a lot now if I'm working with a sort of a surgeon. That I reckon we'll get it done within a couple of hours, but I'm not so sure about the 90.
Great. And then this is all well and good for the first little while, but multimodal analgesia is added, like you mentioned as well. Can you elaborate a bit on that?
Sure. I mean, as you say, what we do is technically with our regional blocks is just one small part of it. You need a pathway, and most hospitals will have this nowadays, and GERF in the UK has made sure that it's virtually impossible not to have a pathway because they want to see it. So standardized pathway. So ideally everyone's on board with giving the same thing to patients across the board, or certainly limiting variance in techniques. And they are evidence-based, and this is our pathway. I don't expect you to be able to see the details necessarily, but there are components there to for simple patients, for complex patients, to tackle the anterior innervation, the posterior innervation, and they are sort of evidence-based techniques. It's all the simple stuff, all the paracetamol, all of the regular. We use quite a lot of COX-2 inhibitors. We use celecoxib quite a lot. And then drugs to stop the side effects of those. So we use gastroprotection on top, regular antiemetics for the first couple of days, and they're going to need some opiates. So again, whatever opiate you use, we're going to change ours from oxycodone, which has been a mainstay of a lot of arthroplasty regimes. We're going back to oral morphine soon. It's quite nice, the idea of having a fixed amount of a drug to take home, because you don't want them to think that they're going to have patients to think that they're going to have something different to what they're going to have in hospital.
Yeah.
So a lot of places you can get them taking their TTA drugs in hospital, so that they know that they're on the same meds as when they. So it's all about messaging to the patient. We need you to get up and walk.
Yes.
It is going to be sore, but you need to kind of push through it. And it just takes one person in that chain to kind of undo all of that. That they, on their admission, an HCA goes, or I expect you'll be in for a week, and suddenly all of that positive messaging has been undone. So it's about getting the whole team on board. But we're looking to, obviously keep opiate use down, stop opiates at, ideally, if you can, at a week maximum, and limit their side effects.
Mm-hmm. And that's part, I guess, of the preparation way before.
Yeah, I mean, ideally will happen before the patient gets to hospital, but a lot of places, have joint school and things like that. I mean, ours is, I think, fallen by the wayside, but pre-op education and expectation setting is really, really important, and so that everyone. And one of the first things I say when I see the patients is, I talk them through and I talk about the balance between analgesia and mobility, and that they will still have some pain, which we will manage, but they're not going to have a completely numb leg, that they may have some motor block, but we're aiming to get them to the point. But you've got to choose your, you
got any tips on how to,
yeah, I mean, this is one of the things. So particularly in a centre, we're sort of the, here at Derriford, we get a lot of the patients that other centres locally won't necessarily choose because of the comorbidity, and so they're not necessarily going to be the people that are flying out of hospital the quickest. And so you need to try and spot those patients if you can, but unfortunately it's very hard to work out what is the variable to that is going to keep these patients in hospital. And if you could say, well, it's obesity, but it's not obesity. Some of our first patients that went home were patients with BMI 50 and BMI 45, so patients went home the same day, so that debunks that. So there are a lot of factors, but if it's likely, if you come in a wheelchair, or not having left an armchair for 6 weeks, you're probably not going to be flying out of hospital, and maybe your choice of technique needs to reflect that, and maybe those are the patients where we prioritize analgesia. And there's a nice editorial that came out, it was published in Anaesthesia last year or the year before, about just exactly this, really, that motor sparing regional anaesthesia has perhaps, for some patients, shifted a bit too far. We've got to balance both the analgesia and their function. So they've suggested, it's a really simple idea, but first of all, are these patients going to be able to mobilize? If they're not, well, let's prioritize their analgesia. Are they going to be able to cope with the pain and manage that? So if they're on chronic opiate users or chronic pain conditions, then maybe not. And again, prioritizing analgesia might be more important. And then, is your institution set up to make the most of it? So if there's no physios, and the ward nurses can't mobilize patients, then there's not really much, and the patient is not going to get out of bed that day just because of the infrastructure around them. Then you might as well prioritize their analgesia. There's no point in them being able to move around and be in more pain than they need to be. And are they at risk of complications as a result of being in pain? So it's just, a bit of a brake check on the whole movement, which has definitely been the case, certainly within the UK, constantly motor sparing, got to get the patients up. And certainly we want to do that, and do that wherever possible. And it may be, you just have to take components of that and of what you're doing. Quite commonly, we'll do a femoral triangle block. I won't necessarily do a femoral nerve block in everyone. If I've got good views and I can get a good result, I'll do a motor sparing option there. But if maybe that they've got a lot of pain issues, I might do an isolated tibial, which is perhaps a sort of a second line treatment. So sometimes it's about putting things together.
And do you think we could go kind of through ACL reconstruction now.
Yeah, so there's not really a lot to say about ACL reconstruction in terms of regional anaesthesia, fortunately. But it depends a bit about what graft they're taking. So for most patients, they'll have a hamstring graft nowadays. There are places now that do quads tendons, and there's also allergenic grafts, sometimes very rare, or cadaveric grafts. But for most of our patients, it'll be a hamstring graft. And that influences the sort of the pain and things afterwards, and what blocks we need. So the mainstay used to be historically a femoral nerve block. Again, mobilization. These are day case patients. It didn't used to be so much of a problem because they all used to go into a leg brace, and so we used to be able to put a femoral nerve block in, and the patients would go home in a leg brace relatively safely. But that's a lot of our surgeons are not doing that now, and so we do a femoral triangle block for those. Okay, and there's an evidence base for that, albeit a lot weaker than for knee arthroplasty. The magnitude of effect is less severe, and you know, a lot of these patients will do well just with surgical local. And there's a real spectrum, but you know, I find generally it's about 10% of them that get really sore. Others are generally fine. So I tend to do a femoral triangle block. In terms of other blocks, the iPACK block has been shown in studies to not really add much. However, my anecdotal experience is slightly different, and you know, I've done it on sort of some patients where I was perhaps being held to account by colleagues a bit more because it was their kids, and they got a good result from that. And so, you know, I'm not so sure. Could it just be that, you know, how they're wired? There's also a bit of weak evidence for genicular blocks, a couple of studies which have shown a benefit, but I wouldn't go rushing to do all of those things. A lot of the pain they get afterwards is from the hamstring graft site, and they can get a lot of hamstring spasm, and none of them what we're going to do is going to touch that. So it's the usual multimodal and things. So femoral triangle block is your one go-to block for that, really, I would say.
Okay, great.
And the surgeon will put local in to the rest.
Excellent. Thank you. We've gone through a lot there. I'm just going to look at Slido. If you've got any questions, do you want to ask them now? I will double check.
Or you can put them in the chat if there's.
So I think the pro position, Max's knee obscured the pro position you made for the iPACK block. Is there any chance you can show people on Max's left leg?
Yep, sure. Assuming it was the iPACK
block.
Yeah, so it's really the same as if, I don't know if
maybe if Max moved it there.
Yeah. It's quite hard. It's quite hard when they're quite a small room. So I'm in behind the knee like that. Okay. So I need to actually put this on to scan. So I don't think it's going to show so well because I'm rocking my probe distally to look at the condyles of the knee. There's the condyles of the knee, and coming back, and the femur is flattening off at this point. Sorry, Max, you're moving. Everything's moving here. So rocking forward into the condyles of the knee and back. So we're just a bit further down from where we would do a popliteal sciatic nerve block, and it's just about tilting your probe, really. You can't really go wrong. You're just going to look for that view of the condyles coming into view and then flattening off. And so you're quite distal in the knee. So you're probably about 2 or 3 centimeters more distal to where you'd start to do a popliteal sciatic nerve block.
Great. I've got another question. Is it okay to use 2% chlorprep sticks for cleaning for these blocks?
So for the yes, I use them for the genicular nerve blocks. You know, I know there's the whole argument about neurotoxicity. I don't like. I prefer to use 0.5% for most of my other blocks. But these, we're dealing with small, tiny little terminal branches, and you know, the surgeon is going to prep that area with and then cut through it. I mean, I think the risk is incredibly small, and I don't think there's enough evidence one way or the other. So I think the balance of 2% chlorprep here, you know, versus the risk of infection is probably worth taking that marginal risk if there is any.
Let it dry. as well.
Yeah, let it dry. Yeah.
Is it just me, or do you struggle to get good surgical anaesthesia with 0.25% bupivacaine?
Sent by
Not
anonymous.
great for weight patients.
I think it's a bit more variable. I think with the combination of the blocks, it works okay. The motor block is definitely less, and it does wear off a lot quicker. I know some people have said that. I've not had any disasters. I've had the block kind of resolved because of timing, but then the cutaneous blocks have taken over. So actually, I've been carried by them, and the patient's been moving their leg, but they've still been comfortable. And I think if you were just doing it just with surgical LEA, you may find that is perhaps a bit more difficult. It definitely is not as robust as the prilocaine. Prilocaine is very much a fire and forget block. You put in, you get a nice dense block which lasts for the time and then wears off quite quickly. And so, I probably, if I was on the cusp, would still try and use prilocaine if I could.
Is there any relevance of using adductor canal catheters instead of single shot block?
So yeah, most of the evidence for efficacy shows that adductor canal catheters are definitely better than single shots, but the magnitude of the effect is not so much to make us change our practice. And in certainly UK practice, patients are going, we're trying to get the patients home, so we've not got the setup for domiciliary catheters. It's a nice idea, and I guess there are places that do it. The other practical issues, we did try and put some in a while back, long before we were putting femoral triangle catheters, femoral nerve catheters in, and we were doing a little comparison with adductor canal catheters. They're difficult. So if a single shot adductor canal block is difficult, these are much more tricky. And to get them to stay into place, I think it's much more of an advanced level skill, and it's difficult to do before pre-op, because you've got where you're going to leave it. The surgeon's going to to tourniquet on the leg, and it maybe gets shifted, and afterwards you've got a dressing here, so you've got to kind of peel back the edges of the bandage and things. So it's just the logistics of it all, and I don't think it's really warranted. I think it's good enough without.
What tends to be your recommendation as the must-do blocks for knee arthroplasties based on your experience? You've sort of gone. Can you go back to that slide, Sam, that sort of showed that? I think it was slide 6. No.
So I mean, again, our must blocks are the blocks you need. You need a femoral triangle block, and you need an iPACK, and that will set you up for working in any kind of modern NHS hospital, which is trying to meet girth's requirements. And then you need to be able to do, for when you can't see anything, you need to be able to do maybe a femoral nerve block. And then it's nice to do an isolated tibial nerve block, though there are very few patients you can't put an iPACK into, or the surgeon can't put posterior capsule local in. So I wouldn't get too beaten up by the isolated tibial. But that's a skill that most people will have, because they'll come having done sciatic nerve blocks in the popliteal fossa, so it's just a continuation of that. So really, the one take-home thing is the femoral triangle block.
And there's one other question here: why are we not considering ropivacaine for spinals yet?
I have no idea. I'm sorry. No experience of using ropivacaine for spinals. I suspect you probably got more experience than us on that. I'm not sure about its longevity in the spinal. I don't know if it produces more or less motor block and faster resolution. But the move is towards the short-acting spinals, which are just very, very dense block, very hemodynamically very stable, and there's no messing around, because historically, to get short-acting blocks, we had to dilute down bupivacaine, put some opiate in it, this and that. It was all very nuanced and difficult, whereas this is just done, and predictable.
Excellent. I don't think we've got any further questions.
Apologies for our technical gremlins at the start. We did prep everything, and the best laid plans and all that, but hopefully it didn't detract too much from the session for you.
And you'll see on the SOWRA Sessions website when the next date will be, and sort of future plans of various blocks we're going to be doing. But yeah, thank you very much, and I hope you enjoyed it, and hopefully see you next time.